Hi, my name is Ella. I'm a PGME with OB, and I'll be talking about the window of opportunity for cancer prevention, so looking at the rates of Metachronous, BRCA-associated breast and ovarian cancers in BC. I'd like to thank the scientific committee for having me here today, as well as BC Cancer and Dr. Kwan for supporting my work with this project. I have nothing to disclose. So a bit of background, BRCA1 and BRCA2 are both tumor suppressor genes that repair DNA. In a small proportion of individuals, they may have mutations in both BRCA1 or BRCA2 that increase their risk of developing both breast and ovarian cancer when compared to the general population. It's this high lifetime risk of ovarian cancer specifically that's concerning to gynecologists, as there's no current effective screening test for ovarian cancer. Because of this, the majority of these cases are diagnosed at advanced stages with a reported 5 years or 10-year survival of only 35% in the literature. The literature has also reported that for patients with an index BRCA-associated ovarian cancer, that they remain at risk of developing metachronous breast cancer at approximately 10% in 10 years. With novel treatments for BRCA-specific ovarian cancer, for example, medications like PARP inhibitors like olaparib, which have improved survival to 67% at 7 years, these patients are now living longer, but this means that they remain at risk of developing metachronous cancers, or specifically in this case, breast cancer. For patients with index BRCA-associated breast cancer diagnoses, as they are expected to survive their index diagnosis, the rate of developing subsequent ovarian cancer has been reported about 15% in 10 years. So for these patients with index ovarian and breast cancer diagnoses, if there's no family history of cancer, then they may not know that they've inherited a BRCA mutation, and subsequently not know that they're at risk for metachronous cancers. So for individuals in British Columbia, they're advised to have genetic testing for breast cancer if they're diagnosed at a young age, or if they have specific markers, for example, triple-negative breast cancer, which is relatively uncommon in the general population, but more common among BRCA1 individuals. Similarly, patients with non-mucinous ovarian cancer, such as high-grade serous ovarian cancer, which is the most common type, they're also eligible for genetic testing. And it's important to note that this criteria is irrespective of family history or ethnicity. So how do we reduce cancer risk in BRCA? So having an understanding of an individual's BRCA risk is important, as it not only allows opportunity for screening, but also preventative intervention. So for ovarian cancer, unfortunately, there's no current screening available, as CA-125 and ultrasound have not been shown to be effective at preventing the development of ovarian cancer. There are, however, recommendations for risk-reducing bilateral salpingo oophorectomy as the only intervention that's actually been shown to reduce the risk of developing ovarian cancer in this population. And it's generally recommended at an early age prior to the cancer developing. In breast cancer, there is screening with both mammography and breast MRI, as well as the potential for risk-reducing bilateral mastectomy with or without reconstruction. So our objectives were to explore this in the British Columbian population. So first, we wanted to assess the rate of metachronous cancers in individuals with index BRCA-associated breast and ovarian cancers, and then review the time interval between these diagnoses, rates of genetic testing, to determine if there were opportunities for risk-reducing intervention. So in order to achieve this, we used two databases. The first was the BC Cancer Hereditary Cancer Program High Risk Clinic. And so we found that of the 1,378 index BRCA1 and BRCA2 patients, that there were 235 index breast cancer and 50 index ovarian cancer cases identified. Of these, we found that 15 had breast cancer and then subsequently developed ovarian cancer, and that 3 had ovarian cancer and then subsequently developed breast cancer. Because individuals in this high-risk clinic don't represent all of the individuals diagnosed with BRCA-associated cancer in the province, we also looked to the BC Cancer Provincial Pharmacy database and used the medication olaparib as a surrogate for ovarian cancer that was BRCA-associated. We looked and found that there were 17 patients who had breast cancer treatment prior to being treated with olaparib, and 3 that had breast cancer treatment after being treated for ovarian cancer through olaparib. And we specifically looked at olaparib codes that were associated with BRCA ovarian cancer. So then when we merged these two groups, we found that of the index 252 breast cancer cases, we found that 11% developed metachronous ovarian cancer at a median interval of about 12 years. We found that 78% would have been eligible for genetic testing according to the criteria I previously showed at their index diagnosis, but that only 71% of these individuals actually had genetic testing. When we look at the 71% that had genetic testing and were eligible, we find that 2/3 underwent risk-reducing surgery. This happened at a median age of 58.5 years, so well beyond the recommended interval that I previously showed as well. We found that, and again, this is specifically looking at people who did develop metachronous cancers, that 80% of these patients actually had their subsequent cancer diagnosed on their risk-reducing intervention. Because of this, the stage distribution for these cancers were largely stage 1 and 2, and this is in comparison to patients who did not undergo risk-reducing surgery, and the majority were diagnosed at advanced stages. We also looked at patients who developed breast cancer after ovarian cancer. So of the 221 index ovarian cancer cases, 3% developed metachronous breast cancer at a median interval of about 5 years and a median age of about 61.5 years. We found that 100% would have been eligible for genetic testing at their index diagnosis, and that 100% actually had this genetic testing done. So for these individuals that knew their BRCA status, all of them elected to pursue screening for subsequent breast cancer, and no risk-reducing mastectomies were performed in this group. It's important to note that the subsequent outcomes for these patients were largely driven by their ovarian cancer diagnoses, and that all of the breast cancers were diagnosed at early stages. So the key takeaways from the study are threefold. The first is that there is an interval between the cancer diagnoses. Between breast and ovarian cancer, there's 12 years, and between ovarian and breast, there's 5 years. That we found that 30% of our eligible breast cancer patients did not have genetic testing after their primary diagnosis, and that 2/3 of breast cancer patients with known BRCA elected to pursue risk-reducing surgery, but this was occurring at a median age of 58.5 years, so beyond what was recommended. So our conclusions are that patients with BRCA-associated BRCA pathogenic variants do have a high lifetime risk of breast and ovarian cancer, and that in British Columbia, we are seeing these metachronous cancers as well. So if a patient has one diagnosis, they should be counseled about subsequent risks as well. We found that both breast and ovarian cancer patients are often eligible for genetic testing, but that there may be room for improvement, specifically in the rate of genetic testing for these breast cancer patients. And that finally, if BRCA testing in a breast cancer patient confirms a mutation, then these individuals should be counseled on risk-reducing surgery for subsequent cancer risk, but ideally this should be done at an earlier age, and we should be intervening earlier for these patients. Thank you so much for your time.
Can you just briefly explain about olaparib and how that is used and why that might be used to ascertain these patients?
Yeah, thanks so much for the question. So we use olaparib specifically because it has been shown to improve survival in BRCA-associated ovarian cancer cases. And so we knew that the provincial pharmacy database had a specific code that they associated with patients who were getting olaparib for BRCA-associated ovarian cancer. And so we used that code as kind of our search criteria in the provincial pharmacy database, and then we're able to cross-reference patient charts and confirm that they did actually have BRCA-associated cancer.
And there's no other cancers or no other situations where that medication might be used?
There are other situations where it is used, but it's under a different code. So we were luckily able to screen more specifically for these, but we might have missed some patients that were maybe treated for multiple things and then also had breast cancer. Yeah.
Oh, I think it's me first. Sorry. You mentioned that there was a significant number that didn't get you would have qualified for genetic testing but didn't get that. But I think the interval, I may have been mistaken, is kind of over almost a 30-year interval. Can you comment on how that's evolved over this 30-year span as genetic testing has become more prevalent?
Yeah, that's an excellent question and a great point. So our study did span quite a number of years, and it included a time period where there wasn't direct referrals from oncology to genetic testing, and there was the process where they had to go through a genetic counselor. And so I think in our older or our more historical data, we did see that there was a lower rate of genetic testing after the index case, but that in our more contemporary patients, that there was a quicker turnaround. So hopefully, as that pathway goes on, we'll have more data that shows that it's been improved.
To what extent do you feel like your results are limited to BC because of structural, institutional ways in which this process is carried out, or how much can it be extrapolated to other provinces or other places around the world?
Yeah, thanks for the question. I recently presented this project at ACS in Chicago, and looking at their criteria for genetic testing and also their rates, it was pretty similar, if not a little bit worse than ours. So I do think it's pretty comparable, and within BC, it's nice because we have everything kind of provincially collated. So hopefully, it'll be a good model for other places as well. But thank you for the question.
Just one quick last question. They're doing opportunistic self-injectomy and oophorectomy for patients who undergo other types of abdominal surgery, they do it at the same time. Do you think there's a role for that for, I guess not just even BRCA patients, but just patients in general to reduce risk of ovarian cancer and maybe even identify potential BRCA patients?
Yeah, I think that's a great point. I think that that's a great intervention that's been going on. So I think if patients, are past the times where they want to be fertile, then that's something that we should be discussing with them before they're undergoing other elective surgery. Okay, thank you.